Good morning to all. So, today's class is on burn. It is divided into two classes. Now, often I ask the students, what is burn? And they tell, sir, fire, sir. So, we have to know what is burn and some basic questions in the first part. That is, one's clothes catch fire, is it burn? Number 2, what is burn and what is scald? Number 3, when and where to admit the patient. This is when you have passed the MBBS and will do your emergency duty, you have to decide these burns will be admitted, a distant bell will be referred to a plastic surgery, and that I will highlight in this lecture. Now, how to assess a case of burn? How do you assess? And number 5, is there any first aid for burn? Number 6, why is mortality high in burn? Now, in university questions, every alternate year you will get these questions. That is, a female patient aged 45 years and body weight 60 kg or 50 kg has been admitted with either 60% burn or 70% burn or 80% burn, surface burn. How to manage the case? This is a very, very common question in university examinations. And again, short notes is complications of burn, and third short note is rule of 9 in burn. Now, what is the definition of burn? Burn is not a fire mainly. Burn is coagulation necrosis of skin due to some physical agents, and common place of burn is our kitchen. Now, what are the types or causes of burn? So, this may be thermal, this may be electrical, this may be chemical, this may be ionizing radiation and sunburn. Thermal burn again difference, there is scald and flame burn. Now, what is scald? Scald is the burn due to a hot liquid is called scald, and you know the flame burn, and flash burn is seen in our electrical burn. That is, electrical burn may be a conduction burn, that is due to passage of electricity, and again there may be a flash, and that will flash burn, and there may be contact burn, that is found in a chemical burn, the acid burn, and acid burn, hot liquid burn or alkali burn. Now, then electrical injury and chemical burns, acid, alkali, ionizing radiation and sunburn. Now, classification of burns. Now, this is most important for admission and treatment. That is minor. This depends upon the surface of the burn area. That is, in children less than 10%, I shall come into the what is the percentage, how to calculate the percentage of burn. Then less than 25% may be treated on OPD basis. Now, moderate 25 to 40% in adults, 10 to 20% children must be treated in general hospitals. Major means 40% of the surface burn in adults and more than 20% children. This is one. Then all electric burns involving face, neck, because there is chance of inhalation. More dangerous burn is inhalation burn, and then eye, ears, feet, hand, perineum. Burns with fractures or major mechanical trauma. Patient should be admitted in burn unit under plastic surgery. What is the beauty of this burn unit? This is the AC room to temperature control, because these burn patients suffer more from hypothermia, and there will be barrier nurse. In general hospitals, the one nurse serves one infected patient and then again serves the burn patient. So, there is chance of infection, but there is barrier nursing in the burn unit. Now, depending on thickness of skin involved, now first degree only epidermis affected, second degree involves epidermis and dermis, third degree, that is charred parchment, painless, insensitive, and there is Ester formation. What is Ester? This is a common oral question. What is Ester? Ester is a thick layer over burn surface formed by dried necrotic tissue and secretions, and it indicates the deep burn. So, an Ester formation indicates it is a deep burn. 4th degree involves underlying tissue, that is muscles and bones. Now, Esters, there is a formation of Esters over the burn surface, and underlying these there may be a infection. So, and they produces a compression over the chest or arms. So, we must incise over the Ester, that is called Esterotomy. Now, assessment, how to assess burn? Number one, very important, that is your common question, that is Wallace rule of 9 for early assessment of burn and degree of burn, that is the 4th degree discussed. Now, this is the rule of 9, that is head 9%, head and neck 9%, upper limb the 9%, front of trunk 18%, back of trunk 18%, then lower limb the 18% and 18%. In children, this is to some extent different. Now, in perineum 1%. Now, if there is a half up to thigh, so this will be half. So, in this way, if only one part of trunk, then it will be only 80%, in half this will be 9%. In this way, you have to calculate. Rule of 9, head neck 9 again, front of and trunk of 18%, back of trunk 18%, upper limbs 2 into 9 18%, lower limb 2 into 18 30%, and perineum. So, total is 100%. Now, this is the burns 1st degree up to the epidermis. This is the epidermis, this is the 2nd degree, this is the dermis, this is the 3rd degree, this is the subcutaneous tissue, and 4th degree, that is the muscle. So, these are the 4 degrees, very easy. Now, grade 1st degree up to epidermis, dermis, subcutaneous tissue, muscle. This is the Ester, there is a burn here, and there has been a necrotic tissue and dried over this is called Ester. Now, if this is compression over the chest, etc., there may be a incision, this is the incision, and lateral incision mainly. So, to release the compression, this is called Esterotomy. Now, the burns in the pathophysiology, so burns is a local disease, local condition, but it produces the systemic effects, just like your ulcerative colitis. This is a local disease, produces the systemic effect. Acute pancreatitis, local pathology, but produces the systemic effect, such as burn in the heat, the coagulation necrosis of skin, that is burn, release of vasoactive peptides, capillary permeability, fluid loss, hypovolemia. This is so hypovolemia. And at the first there will be very much pain, so there will be neurogenic shock, and decreased cardiac output, myocardial dysfunction, and pulmonary resistance altered. So, there will be pulmonary edema, infection, and multi-organ disease. Decreased renal infiltration, so oliguria and renal failure. Renal changes, so from muscle there will be myoglobin, and there will be myoglobinuria, and there will be kidney damage. GI changes, the common GI changes is there may be even a ulcer formation and acute cholecystitis. This ulcer is called curling ulcer. So, what is curling ulcer? Curling ulcer is seen in the stomach, in burn, it is a stress ulcer. Now, in cardiac dysfunction and pulmonary changes, pulmonary edema, so aspiration, septicemia, and ARDS. Metabolic changes, hypermetabolic rate, so negative nitrogen balance, then electrolyte imbalance, deficiency of vitamins, minerals, and metabolic acidosis. Sepsis. So, when there is a burn up to 3 days, there will be no infection, because all the surface bacteria are dead. Now, 3 to 5 days there is gram positive bacteria appear on the wound, but after 5 days or 7 days there is the negative gram negative organisms come, and this is most dangerous. And so, this period, that is when gram negative organism come, that is the patient may suffer from the endotoxic shock and patient may die. So, this is sepsis and septic shock, and more common in diabetic, elderly, COPD patients. 0 to 3 days there, again there is no organism, 4 to 6 gram positive organism. After 7 days there will be gram negative. So, after 7 days there will be more dangerous. So, you have to add the antibiotic which can cover the gram negative organism. Now, what are the causes of death? The causes of death are neurogenic shock, immediate, hypovolemic shock, septic shock and so this is immediately, this is up to 3 days, this is up to 7 to 10 days and multi-organ failure on 21 to 30 days. Now, management of burn, the first aid. So, you will see that many people apply many things, some apply the diesel oil, some toothpaste is common, but toothpaste has no benefit. So, the most important first aid is irrigate with tap water, even you can apply honey, you can apply also on burn surface. Now, when you admit the burn patient, moderate or severe burn, any burn involving airway, extremes of age, on electrical and deep electrical burn and more than 25% surface burn. Now, initial management, remove clothing, cooling by running tap water, cleaning, tetanus toxoid and immunoglobulin, tetanus immunoglobulin. Burn dressings, then sedatives, painkillers, immediately you have to apply painkiller and painkiller to prevent the neurogenic shock. Now, definitive treatment, admit, airway, breathing and circulation. Now, degree, type, percentage, burn unit, AC, sterile clothing, sheets, barrier nursing, sedation, analgesic, IV fluid. These are the principles. Now, fluid resuscitation Parkland regime, that is 4 ml per percent burn and weight of body in kg. So, maybe 80% burn, but always will take the 50%. So, if you apply more than 80%, then calculate, there will be more fluid, there will be pulmonary edema and patient may die due to pulmonary edema. So, there will be administered in 3 rations, half of amount in 8 hours, second ration 1/4 in next 8 hours and third ration 1/4 in next. This is very important. So, we calculate the fluid in first 24 hours. This time will be calculated from the time of burn, not from the time of admission. Now, fluids use ringal lactate. What is ringal lactate in the fluid choice? Why? Because ringal lactate, the composition is almost to plasma. It enters into the circulation and capillaries, it do its job and then again excreted through urine. So, ringal lactate just like plasma in this case can replace the volume. So, first 24 hours only crystalloid, that is RL, ringal lactate, next 24 hours RL plus 5% dextrose, after 48 hours you can evaluate colloid, that is our blood transfusion or other colloid solution. Now, crystalloid can pass through capillary wall, RL, dextrose, saline and isotonic saline, but this RL ringal lactate is used. Now, colloid retained in the intravascular compartment draws the fluid more, so there will be more hypovolemia and shock. Now, urinary catheterization, you will have to catheterization to monitor urine output, measurement of pulse, BP, carbon dioxide, that is just the vitals of then proper IV antibiotics, IV ranitide for prevention of curling ulcer. This I discussed when I discussed the university questions in the day 2. And oral cavity hygiene, and you must add the total parenteral nutrition because this must be through central venous line. If patient has got more than 40% burn, you must do a central venous channel. Local management dressing, that is using paraffin gauze, you can biological dressing, lighted amnion and cadaver skin and open method, usually this is preferred. Application of silver sulfatazine without any covering, especially for head, face and neck. And recent treatment is immediate tangential excision with skin grafting. You remove the skin area and the immediate skin grafting and can be done within 48 hours in patients of deep dermal burn. So, the most complications you see in your locality, that is the burn, suffered from burn, there is burn contracture. So, if there is a burn contracture, who is at fault? The surgeon or patient or doctor? Doctor will be at fault because the important 50% treatment by all these drugs, IV fluid, etc., and 50% by the free treatment, that is by exercise or physiotherapy. So, this physiotherapy must be started from 7th day to prevent this contracture. The peculiarity of burn contracture is it occurs on the flexor area, not extensor area. That is contracture will be flexion of the neck, flexion of the elbow, flexion of the hip, etc. So, extension exercise must be started from the 7th day. This may be active exercise or by passive exercise. Now, another complication is the late complication. I come later on, that marginal ulcer is actually the ulcer, and a long lasting ulcer, there will be malignancy develops, that is squamous cell carcinoma, that is called the marginal ulcer. Now, contracture, the joint exercise during recovery start from 7th day again. Pressure elements for long period, that is been placed in America, and topical silicone sheets, but saline expanders for scar, this is not available, but you can start the joint exercise from 7th day. So, thank for the first part.